Very good evening, one and all. I'm Ronak Panwala from Medical Affairs team of Bayer team. So we are thankful to Dr. M.B. Agarwal sir for providing us this opportunity to support this important webinar on recent advances in the landscape of venous thrombosis. As the innovator of rivaroxaban, we Bayer team have committed to innovate, support scientific endeavors, support research in the scientific field, and of course in VT we have been one of the leading pioneer previously and also recently, and we are committed to all kind of education activities, researches on VT and overall NOACs going ahead. So without wasting further time, I would really thank once again Dr. M.B. Agarwal sir and Mumbai Hematology Group for providing us to support this meeting, and we welcome all of you, including chairperson, guest speaker, and invited all the moderators. So over to you, Dr. M.B. Agarwal sir. Thank you.
Thank you, Mr. Ronak Panwala. I'll just share my screen. So good morning to one and all. Today our guest speaker is Lieutenant General Dr. Velu Nair from Ahmedabad. He will speak to us on recent advances in the landscape of venous thrombosis. This webinar is brought to you by Mumbai Hematology Group. It is supported by Bayer, managed by Mice Ideas. I thank Mr. Ajit Telavne, Mr. Mayur Tikam and their team from Bayer, Mr. Rajesh Sharma, Mr. Kalpesh Pambar and the team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. M.I. Kadri from Srinagar, J&K, our guest speaker, Lieutenant General Dr. Velu Nair from Ahmedabad. All our discussants were themselves eminent hematologists, and you participants for sparing your Sunday morning. Next weekend, Saturday, 7 o'clock in the evening, we have Dr. Brad Carl from St. Louis, USA, speaking to us on follicular lymphoma, advances from ASH 2021. And he's also sent a word that he will be covering DLBCL advances from ASH as well. Next Sunday morning, 11:30, we have Dr. Claire Harrison from London, speaking to us on how does she treat myeloproliferative neoplasms in 2022. Now it's time to introduce today's discussants. And we have once again a large number of them, very eminent personalities, and it's my pleasure to introduce them to you. Dr. Ashish Dikshit from Manipal Hospital, Bangalore. Dr. Sharad Damodar from Majumdar Shah Medical Center, Bangalore. Dr. Srimati Shetty, former Scientist F, Deputy Director, NIH, ICMR, KM Hospital, Parel, Mumbai. Professor Chandrakala from Department of Clinical Hematology, KM Hospital, Mumbai. Dr. Aleem Jan, former Professor Clinical Hematology, SKIMS, and now hematologist, hemato-oncologist at Srinagar, J&K. Dr. Satish Kumar from Manipal Hospital, Yashwantpur, Bangalore. Dr. Mukul Agarwal from AIMS, New Delhi. Dr. Akanksha Garg from GCRI, Ahmedabad. Dr. Shilpa Prabhu from Majumdar Shah Medical Center, Bangalore. Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune. Now we have our Sunday quiz. So today's quiz will be in the next slide. And this time you have to answer and send an answer to this email ID, mbagarwal1@gmail.com. And the winner will be fastest finger first. And we will also be declaring names of all those who send the correct answer. Okay, so you will be answering by email to mbagarwal1@gmail.com. Now, have a good look at this picture. At the bottom, there are 3 hematological conditions. Hemolysis secondary to antibodies, so autoimmune hemolytic anemia. Microangiopathy due to antibody against ADAMTS, that is TTP. And acquired hemophilia secondary to antibody against factor 8. So you've got 3 acquired autoimmune disorders. At the top, you see B lymphocyte and the plasma cell. And at the top, there are 2 treatment modalities. The one treatment modality is written here, rituximab, which is effective in all these 3. And the second modality, there is a question mark put over here with arrow to B lymphocyte and the plasma cell. You have to predict the name of this drug. And that name you have to email to the email ID that was given to you. mbagarwal1@gmail.com. I'm going to keep this picture on for you for a while. Okay. So send your answer to mbagarwal1@gmail.com. Winner will be the fastest finger first, and we will also tell you names of all those who send in correct entries. We now come to the case of the week. And this is a case of persistent leukocytosis. A 70-year-old man, a known case of polymyalgia rheumatica and giant cell arteritis, receiving steroid, was referred for persistent leukocytosis. The leukocytosis coincided with the initiation of corticosteroid therapy. Physical examination from hematological angle was uneventful. There was no pyloricterus bruising, enlarged liver, spleen, or lymph nodes. The hemogram shows a WBC count of 27,330, hemoglobin 12.6, and the platelet normal. The differential WBC count shows 91% neutrophils. This leukocytosis with neutrophilia was attributed to steroid therapy and or the underlying inflammatory disorder. 3 months later, patient was admitted for shortness of breath. Community-acquired pneumonia was found and it was treated accordingly. Imaging showed bilateral pleural effusion and hepatosplenomegaly. Blood culture were negative. Compared to the prior hemogram, lab now showed a little more prominent leukocytosis with a mild left shift. And this was in the setting of his pneumonia. The white cell count now was 54,000, hemoglobin 11, platelet normal. The peripheral blood film showed marked neutrophilia. His neutrophilia, however, persisted even after control and clearance of pneumonia. It is at this stage that the patient was referred for hematological opinion as the neutrophilia was worsening and didn't disappear despite control of infection. Thus, the peripheral blood film showing you an extreme degree of neutrophilic leukocytosis. Bone marrow aspiration biopsy were done. Both showed hypercellular marrow composed entirely of myeloid series. There was no dysplasia, no reticulin fibrosis. There was no increase in CD34 positive blasts. Molecular workup for MPN, BCR-ABL, JAK2, CALR, and MPL were all negative. Chromosomal analysis showed normal karyotype. Thus, the bone marrow aspirate showing you intense myeloid hyperplasia with orderly maturation, no blast, no dysplasia. That's bone marrow biopsy showing you intensely packed marrow due to intense myeloid hyperplasia with maturation. Once again, no blasts, no dysplasia. That CD34 stain, once again showing you that there are hardly any blasts. An NGS panel identified 2 mutations involving CSF3R. In addition, there were mutations in ASXL1 and SRSF2 exon. There were no mutations in EZH2, RUNX1, and SETBP1. With CSF3R mutation, the diagnosis with the clinical picture, the diagnosis of CNL, that is chronic neutrophilic leukemia, was made. CNL is a disease of elderly, and it affects both sexes almost equally, as you see in this particular published age bars. Some of the patients are presented with leukemia cutis, and here you see 3 different patients with leukemia cutis secondary to chronic neutrophilic leukemia. CSF3R mutation test is very, very helpful, although not pathognomonic, neither 100% sensitive nor 100% specific, but is present in almost 2 out of 3 patients, either alone, like 41% of cases as seen in this study, and together with SETBP1 mutation in 24% of patients. So CSF3R mutation studies are extremely helpful in concluding the diagnosis together with the clinical picture. There are 2 types of mutation: membrane proximal mutation and cytoplasmic truncation mutation. Now, it's important to know the difference, because if it is membrane proximal mutation, then it activates the JAK-STAT pathway, and the treatment here is ruxolitinib. While if it is due to cytoplasmic truncation mutation, then it activates the SRC kinase pathway, and the treatment is dasatinib. This is an algorithm for treating this particular condition. So if you have CSF3R mutation, and with that, if you have membrane proximal mutation, then ruxolitinib is the treatment. If you have truncation mutation, then dasatinib is the treatment. If CSF3R is not mutated, look at JAK2, and if that is mutated, it's ruxolitinib. And if even that is not mutated, the treatment is hydroxyurea or interferon. And as and when acute leukemia develops, AML type of treatment or allogenic transplant. Patient was advised to take ruxolitinib, but because of the cost involved, patient opted and was treated with hydroxyurea. 3 months follow-up showed normocytic anemia with improved leukocytosis. White cell count dropped to 15,000, neutrophil 88%. This is a published case showing you the efficacy of ruxolitinib, how it controls the total WBC count, how it controls the absolute neutrophil count, and how it improves the platelet count, and also the hemoglobin. And as and when it loses its efficacy, once again, the total WBC neutrophil count increase, platelet drop, and hemoglobin drops. 9 months later, this patient presented with non-healing ankle ulcer, probably related to hydroxyurea. He also had progressive fatigue. And the blood count showed pancytopenia with blasts, 42% in peripheral blood film. And the flow showed this to be a B, acute lymphoblastic leukemia. These are the peripheral blood blasts. That's a bone marrow showing you intense packing with blasts, which the cells were CD34 positive and CD79A positive. In summary, we saw a case of CNL today who had numerous genetic alterations which rapidly progressed to acute leukemia. These observations highlight the often aggressive clinical course of this rare chronic myeloid malignancy and supports the evidence that if the mutations involve ASXL1 or SRSF2, then the response to hydroxyurea is poor, outcome is poor, and chances of developing acute leukemia is high. The prognostic and therapeutic implication of CNL harboring multiple CSF3R mutations, as in our patient, is uncertain. This is the published data on patients of CNL with ASXL wild type versus ASXL mutated type. And you can see the survival is grossly different. To summarize, transformation to B-ALL in our patient was interesting. Together with the recent observation that CSF3R truncation mutation has been described in occasional patients of B acute lymphoblastic leukemia, these findings illustrate a unique nexus between chronic neutrophilic leukemia and B acute lymphoblastic leukemia. There is suggestion in literature that combination of CSF3R, ASXL1, SRSF2, and RUNX1 mutation may drive B-cell leukemogenesis. That was the case of the week, and now it's my privilege to introduce our guest speaker of the day, who is going to inaugurate our webinar. And that is none other than a famous personality in the field of hematology in India, from JNK, from Srinagar, Dr. M.I. Kadri. And I'm extremely grateful to him for having accepted this invitation to be present today, spare his time, and accept to inaugurate our webinar today. He doesn't require an introduction to anyone in the field of hematology in this country and even abroad, but I must complete the formalities. His director, Dr. Kadri's Hematology Center and Clinical Lab, popularly known as DQHCCL in Srinagar, JNK. He's a fellow of the prestigious National Academy of Medical Sciences. He's more than 40 years of experience in the field of hematology. He's a recipient of Commonwealth Fellowship, Royal Free Hospital, London, UK, way back in 1988. Earlier, he was at Regional Lab, Eastern Province, Daman Central Hospital, and Kingdom of Saudi Arabia, where he worked as the head of the department. After retiring as professor and head of hematology transfusion medicine from SKIMS, GMC Srinagar, he established DQHCCL in private sector, and that was 21 years ago. DQHCCL is a government recognized special lab in JNK. This is the first NABL accredited lab in hematology, clinical pathology, biochemistry, and immunology in JNK. His aim of establishing DQHCCL was to provide quality clinical lab services to the people of Kashmir and deliver accurate results in shortest possible time. DQHCCL is a pioneer in bringing automation in the private sector in Kashmir. It's now my privilege to invite Dr. Kadri to inaugurate our webinar and give us the words of wisdom, following which we will have our guest lecture. Over to Dr. Kadri.
Thank you very much. Thanks a lot, Professor Agarwal. And we have the renowned and honored hematologist, Lieutenant Colonel Dr. Velu Nair. So, good morning, and it's yes, good morning. Still, good morning to everybody there, and so nice to interact with those old fellows. And you have given what I have achieved, but let me tell to the youngsters that when I joined hematology was rather unheard as a career specialty. But at the end of my house job in medicine, I wanted to do MD medicine, where I had a very good merit. But I was told, no, you have to go to hematology. And for that, you have to do first MD pathology. Then I was the first Indian to pass by examination, M.A. MS in hematology. And those were the days when Professor B.C. Mehta and others in Bombay were there, and we a small gathering and small association, Indian Society of Hematology and Blood Transfusion. Even at that age, I was a counselor of the this association. And I am just telling you so that I can stimulate and tell to the youngsters that hematology is a very good branch, though I didn't come my job by choice, but I enjoy it. And I think that retrospectively, the advice given to me by then chief of the medicine and Dr. Adi Muhammad Jan, who is considered as Lukman in Kashmir, was really good. And I think I enjoyed it, and it is really rewarding, and rewarding for the patients and rewarding for you. Those patients who never got any treatment, those patients who never got hemophilics, who never got a good treatment, received treatment, and we established hematology and blood banking in whole J&K. So my advice to youngsters will be that this is a very, very refreshing specialty where a lot of new things are coming. Now we started at that time, though we came from pathology, but hematology was a lab oriented, and we at PGI Chandigarh, where I worked under or got trained under Professor K.C. Das, whom we consider father of Indian hematology. We used to run the OPD once a week, and not the medicine people that time. And it was just from Myler on, now we have reached to targeted chemotherapies, and so fantastic, so nice. And my son also took the hematology as a specialty. So I tell to my youngsters that ask people, meritorious people, to join hematology. And Bombay Hematology Group really is doing a wonderful job. It was even during that time, 1975, when I joined hematology, that almost we used to have most of the conferences in the then Bombay and now Mumbai, but they were that time also very active. Dr. Agarwal, Dr. Arwani, under guidance of Dr. B.C. Mehta. So and I'm seeing that we have so many webinars in hematology now organized by Mumbai Hematology Group, and one feels really so happy. Now, even at this age, I am working very hard. It's still very, very hard, working almost 10 to 12 hours a day still. And it's just because there is a lot of work in hematology. So I will advise and rather tell to my younger people that hematology is a good branch, and join and ask your friends to join hematology. And I hope that because the things didn't go well in Kashmir, we had planned a hematology conference in Srinagar. I hope it will be done. Maybe in next 2 years, we will call you all up here. Dr. Agarwal is a frequent visitor to us, and he is doing wonderful job. I should say that he has done so much for hematology. He is doing a really wonderful job, and we have so many good hematologists from Mumbai, and they are doing wonderful job. And we have not so many centers in the Mumbai, and there is no dearth of now hematological centers in India, but the ones in Mumbai and Chennai are really wonderful. So I wish all of you a great success, and I should not come in between your scientific program. And I request Dr. Agarwal Saab to take over and introduce our renowned hematologist, Professor Velu. Thank you very much. Thanks a lot.
Thank you, Dr. Kadri, for sparing your time, being with us, and giving this lovely speech and the message to both seniors and the young colleagues. I can never forget my visit to Srinagar, 1980. Shere Kashmir Institute was being formed, and the post of hematologist was advertised.
Yes,
And
yes.
you and me were the two candidates, and you beat me on that day. You were selected, and for a minute I was depressed that I lost the opportunity of becoming a hematologist in Srinagar. But then, of course, the destiny brought me back to Mumbai, and there have been no regrets. So that was
Hematology is great anywhere, great anywhere. It is great anywhere.
that
So
gave
this
me
is what I was saying.
that gave me the opportunity to see Srinagar for the first time for 3 days. And what a wonderful place that was, 1980. So,
Actually, I should correct that I am the first faculty member of the institute, and I was selected in absentia. The reason was because Professor K.C. Das was expert, and their aim was to get first the professors, and he was offered. Mohanty was offered. They didn't join. Then Dr. Das told them that you will lose your own person because I had a job with Dr. Flemings in Nigeria. So I was going there, and they just took me and bound me to the institute. So I could not join Dr. Flemings. So that was the reason that I was already booked by them in absentia. Anyway, it was my own place, so I had to honor. And credit goes to Professor K.C., late Professor K.C. Das.
thank you so much. I'll just share my screen now to introduce our speaker of the day. Okay, so as was mentioned in the beginning, our speaker today is Lieutenant General Dr. Velu Nair from Ahmedabad. How can I have the audacity of introducing this personality to a group that is listening to us today? Known him for what, 30, 40 years. Always impressed by his dedication, not only to the field of hematology, transplantation, transfusion medicine, but also to the country. And you will just see in next 5 minutes from what I tell you about this gentleman. MD Medicine, FRCP London, FRCP Glasgow, FACP USA, FICP, FAMS, FIACM, FUICC UK, FISHTM. Group Head and Chief Consultant, Comprehensive Blood and Cancer Center, Ahmedabad. Former Director General Medical Services, Army. President's Honorary Surgeon. Dean of AFMC, Pune. President of National Society of Hematology, ISHBT. Gold medalist in the MBBS 1977 from AFMC. First position in Pune University. MD Medicine 1987 from AFMC. First position in AFMC Pune. Postdoctoral Fellowship in Hematology in BMT. CMC Fellow, King's College and Hospital, London. Stanford Medical Center, Stanford University, US. Development of hematology and BMT services in armed forces. He was responsible for coordinating and establishing 7 hematology centers in the armed forces. The front of research and academics, teacher and examiner for MD Medicine and DM Hematology. Keen researcher who has conducted some of the landmark clinical trials on stem cells, hospital infections, thrombosis, and hematological malignancies. Chair of Nuclear Accident Management Committee, APBMT. Chair, co-chair, and member of the various committees in the ICMR, DBT, DRDO, NBE, NABH. Chair, Scientific Advisory Committee of NIV, Pune, and NIH, Mumbai. A pioneer in medical ailments at high altitude with emphasis on thrombosis, and I'm sure this will be a part of his talk today. Elected council member of National Academy of Medical Sciences, NAMS. Publications. He was chairman of drafting committee of hematopoietic stem cell transplantation national guidelines published by ICMR in June 2021. Over 250 publications in various hematological, national, international journals and books, and author of 3 textbooks in medicine. Awards, and I could not list all of them here. Prestigious Presidential Award for Distinguished Services in the Armed Forces, Param Vishisht Seva Medal, Ati Vishisht Seva Medal, Vishisht Seva Medal twice, awarded for excellence in medical education by the National Board of Examination, recipient of 19 prestigious awards from various societies in India. Well, we are privileged once again to Dr. Velu Nair for sparing his time and going to educate us. We have participation from 15 countries today, seniors, juniors, trainees, and fellows. At the end of his talk on recent advances in the landscape of venous thrombosis, you'll be very, very wise. Thank you so much. And over to Lieutenant General Velu Nair.
I'm just sharing my screen. Thank you very much, Dr. M.B. Agarwal, as usual, for your very kind words. And I still remember it was late 90s when I was called by Dr. Agarwal. I gave a talk on venous thrombosis in Sion Hospital. And that was my first exposure to the Mumbai Hematology Group. As already told by Dr. Kadri, they've been in the forefront of academics all through after that. So when he asked me to give this talk today, I chose the subject of recent advances in the landscape of venous thrombosis. I'll be taking you through my journey of venous thrombosis and what types of research we've been involved with. And along with that, what are the relevant clinical advances which have occurred. In the next 45 minutes or so, I shall be talking on the various aspects of this topic as shown here. You have reference to VTE in short, venous thromboembolism, as early as 1271. And in the 1600s to 1800s, we got an understanding of the pathophysiology, courtesy, the one and only Rudolf Virchow. What he enunciated then, that time, still holds good. And in the 1800s to the 1900s for the discovery of various treatment modalities. And here, you have to know about J. McLean, a second-year medical student in St. John's, Johns Hopkins Medical School in Baltimore, who extracted a soluble compound from the dog liver, which had anticoagulant properties. His teacher and professor, Dr. Howell, coined the term heparin, which in Greek means liver. In 1937, a purified form of heparin was injected into humans and its anticoagulant properties were demonstrated. In the 1920s came started the discovery of the oral anticoagulants, and Catholics were dying because of hemorrhagic disorders because they ate contaminated sweet clover. Warfarin was discovered in 45 by Link and launched in 48 as the ideal rodenticide. It was shunned by all the physicians, saying it's a rat poison. Till in 1955, President Eisenhower was admitted in the famous Walter Reed Army Hospital with myocardial infarction. His doctors gave him warfarin. The rest was history. The stigma was removed and the clinical application grew rapidly. This is sweet clover for you, and this is Link. Warfarin name comes from the acronym WARF, Wisconsin Alumni Research Foundation, with a suffix of arin from coumarin, thus the name warfarin. The first thromboprophylaxis study was published as early as 1959 in Lancet by Dr. Sevitt and his group, where they demonstrated in a randomized trial that if you gave phenandione, you could reduce mortality because of pulmonary embolism by 40%. This was a landmark. Venous thromboembolism in today's term encompasses both pulmonary embolism and deep vein thrombosis. And what I want to show you here is, you can see here that this valves in the veins is the area where there are pockets of hypoxia, where there is stasis of blood. And when there is stasis due to whatever reason, then that hypoxia, which gets exaggerated, affects endothelial cells around this area, which have otherwise anticoagulant receptors like thrombomodulin and protein C receptors. They all start dysfunctioning and create a hypoxic environment. And that is the reason why DVT starts in the peripheral blood circulation, cough famously. In the 70s, I remember in the late 70s, when I passed out of school, this was a local disorder and treated by the surgeons. And now we know it's not so. It's a systemic disorder. We've got a multidisciplinary approach. We have DVT clinics today. And so what is the incidence of VTE or venous thromboembolism? By race and ethnicity, Asians are fortunate to be less afflicted than the white and the blacks. In age, as with increasing age, with every decade, it increases, and above 80 years, it's 5 to 6 per thousand. Males definitely are more predisposed, and especially for recurrence, the males are more prone than the female population. Nobody is spared. These are all famous personalities who've all got DVT. Whether you are a sportsman or you are a politician, nobody is spared. Now, what scares me is this graph. By 2050, it's predicted that the rates and frequency will double. The prevalence is poised to double, which is scary to say the least. And why is it scary? Because of these complications. The acute complications are pulmonary embolism and venous gangrene. 30% of DVT cases develop symptomatic pulmonary embolism, and the remaining develop asymptomatic pulmonary embolism. The chronic complications which impacts the quality of life, firstly recurrent VTE, followed by chronic pulmonary arterial hypertension, and then the post-phlebitic syndrome. Fatal pulmonary embolism is responsible for approximately 10% of all hospital deaths. And this is DVT for you on your left, followed by venous gangrene on the right. So just, you must know that recurrence is one of the biggest problems in VTE, especially when it occurs in an unprovoked situation. So you can see here that the risk factors for proximal DVT, the risk factors for recurrent VTE are proximal DVT, obese older age people, male sex, and if there is persistence of residual venous thrombosis on ultrasound, high D-dimer values, and an early post-thrombotic syndrome developing, all predisposed to recurrence. There are various models, and what happens is what you call the post-phlebitic syndrome, which occurs is equally troublesome for the patient. It occurs in 20 to 50% of post-thrombotic syndrome is the frequency which develops when DVT occurs in proximal situations over a period of 5 years. It reduces the quality of life and is costly to treat. What are the risk factors? Raised D-dimer after completion of oral anticoagulants. Occurs more in the proximal than the distal. Extensive iliofemoral DVT, recurrent ipsilateral DVT, obese people, and older age, all predisposed to the post-phlebitic syndrome. The impact of heritable thrombophilia is not to the extent that one is thought. When I was in college, it was told when you have DVT, don't move the patient. He lies still in the bed with the fear of dislodging the thrombus. That has been turned on his head. Today, we know the early ambulation and physical activity not only reduces the risk of propagation, but also reduces the frequency of post-thrombotic syndrome. This is how the post-phlebitic syndrome looks. On the top left of your screen is hyperpigmentation of the skin, venous ectasia, edema, skin induration, and if you cannot stop it here, it goes on to develop venous ulcers. And these ulcers are very, very difficult to treat. You can't even wear a shoe, you can't even wear socks, and it's very difficult to treat because skin grafting doesn't easily take. So this is what you're looking to prevent. Luckily, you don't see so much of this today, but 10, 20 years ago, yes, you used to see them. So definitely, there's no doubt, there's no debate on this. Prevention of VT is better than cure. And how can you prevent it? By VTE prophylaxis, also called as thromboprophylaxis. And whenever you want to give an anticoagulant, there is a dictum. And the dictum is you must rule out any contraindication to anticoagulation. Does the patient have any bleeding diathesis? And if he has a bleeding diathesis, you better know it. Does he have any past recent surgery? And does he have any neuraxial problems like any past intracranial hemorrhage, spinal tumors, recent neuroaxial anesthesia? All these things will impact. So you must rule out any risk to bleeding. And for this, there have been various bleeding assessment models made from Hasbled onwards. but none of them have been sort of properly validated and refined. This remains a gap in our knowledge, but definitely is being addressed. And here you can risk stratify them depending on what factors in the variables shown are affected. Higher the risk in terms of score, higher the risk of bleeding. Now, to address this, some landmark studies have taken place. The first one is the endorsed study, where the venous thromboembolism risk and prophylaxis in the acute hospital patients was studied in a multinational way at a cross-sectional study. India was included. And you can see here, over 68,000 patients were enrolled from 32 countries and 358 sites. In this study, they found that all the people who were eligible to get thromboprophylaxis, everybody did not get it. So what does the statistics show? 52% of this 68,000 were at risk for VTE. And out of this 52%, 45 were surgical and 55% were medical. In the 45% of surgical, nearly 60% got thromboprophylaxis as recommended by the ACCP, while in the medical, only 40% got it. So overall, out of this whole group of 52% of this 68,000, only 50% got thromboprophylaxis and 50% did not get. So there was a high death rate from pulmonary embolism, and there was a failure to institute prophylaxis. The problem was much bigger in the medical patients. And to add that, 80% of the medical patients who did not get it were medical oncology patients. So the interpretation was a large proportion of hospitalized patients who are at risk for VTE are getting a low rate of appropriate prophylaxis. And even today, this is true. That's why we are talking about it. On the medical side, this large meta-analysis of nearly 20,000 patients showed that if you give thromboprophylaxis appropriately, you can reduce fatal PE by 62%, non-fatal PE by 57%, and DVT by 53%. This is all very, very significant. So we did a study on the surgical side in the early 2000s. It was a comparative study of the extended versus short-term thromboprophylaxis in patients undergoing elective total hip and knee arthroplasty in the Indian population. We had nearly 1,000 patients. 795 got anticoagulation for 7 to 11 days. That means till they were mobilized. While in our prospective limb of nearly 200 patients, we gave it for 4 weeks, thromboprophylaxis in form of Clexane. What did we find? We found that the prospective limb, only 1 patient got VTE, while the retrospective limb, 3.2% got it. This was statistically significant. And so we concluded that extended thromboprophylaxis was found to be more effective than short-term thromboprophylaxis. Why we did this study was that's the time that the West Hinduja Hospital, in the South MG Ramchandran from Chennai, all these hospitals gave discordant data saying from very minimal to very high incidence of venous thrombosis in hip and knee arthroplasty. AMI being a multi-ethnic society, we thought we can give the answer because we have a multi-ethnic, nice mix of all societies. So this was our result, saying that we do clot. How do you approach a case of suspected venous thromboembolism? Comes the good old Wells criteria for prediction of thrombosis in the general population called PTP for DVT. So here you see the Wells score for leg DVT. These are the variables given, each one has a score. The highest score is, obviously, you can go on till I think 9 or 10, but definitely if you are scoring more than or equal to 3, you have 50% prevalence in the population of VT. While if you have a score of 0, you have less than 10% prevalence in the population. For the upper limb, the same thing has been done by the Constance score. Now, the diagnostic management of patients, there is a simple algorithm, and this simple algorithm is patients who are suspected of VTE, whether DVT or PE, you have a clinical decision rule, you apply the Wells score. If VT is unlikely, then you perform a D-dimer. If it is negative, you rule out DVT or PE and follow them up. If it is positive, you may follow up and do a compression ultrasonography. If it's a VT likely by the Wells score, then you go on to do a compression ultrasonography for DVT and a CT angiography for PE. And if it's positive, you confirm VTE. Now, one important thing is the D-dimer testing has been refined to the age-adjusted D-dimer threshold. It is calculated as the patient's age multiplied by 10 nanogram per ml of fibrinogen equivalent units. So this is for patients more than 50 years of age. So suppose he's 70 years, so his cutoff will be 70 into 10, 700 nanogram per ml, and not 500, which is normally taken. So that is, you will exclude the false positives. These are the sensitivity and specificity of the various diagnostic tests. The contrast venography has been replaced by compression ultrasonography and nearly 100% sensitivity and specificity. The significance of the D-dimer test, I want to say that central laboratories D-dimer uses various types of assays, and the cutoffs are shown here. And what's important is all of them have a very good sensitivity, nearly 100%, but the specificity is half of this. The same thing has been used as a point of care and has been used in various clinical trials. The cutoffs are shown, the manufacturer's cutoffs are shown here, but the same issue, high sensitivity and low specificity. And the ELISA tests are more sensitive than the latex and the whole blood assays. Sensitivity is more for proximal DVT. Extrapolation is not possible across methodologies. So what are the major diagnostic advances? One is introduction of the age-adjusted D-dimer threshold I just told you. The other thing is they're trying to minimize imaging, especially radiation exposure, CT scans. The other thing is how fast can you do ultrasound? In the Western, place, appointments and getting the patient to do an ultrasound may take time, and it's also costly. So the emergency physicians perform prompt compression ultrasonography with the sensitivity specificity, which is again in the 90s, of the proximal veins with very good diagnostic accuracy, and that's the way they've gone. So the emergency physicians are doing it. The magnetic resonance venography, the MR venography, can come of use to you when a compression ultrasonography is not being able to clinch the diagnosis when you have a high index of suspicion, especially when the patient is very obese. In the pelvis, it's very difficult to actually do it with ultrasound. So you may have to go on MR venography. Also in the chest, the SVC and the brachiocephalic arms, very difficult because the ribs don't give you a window. So MR venography have to be used. Then you have the single photon emission computed tomography, which has now come. And this, there's no, the radiation is much lesser and got very good sensitivity and specificity. So the major diagnostic advances, which I've already told you, are these. And now coming to the cancer-associated thrombosis, these are the certain important parts where VTE is high frequency. 20% of all VTE cases occur in cancer and is the second leading cause of mortality in cancer. And, CAT, as it in short, cancer-associated thrombosis is called, is an independent risk for early mortality in the first 4 cycles of chemotherapy. Indian data in the ARRIVE registry and large multi-centric observation study has shown that 7 to 10% of the malignancies present with VTE in our patients. So what is the overall VTE incidence? The overall VTE incidence is 12.6% compared to the general population of 1.4%. And what is by cancer types? The leader is pancreatic cancers, followed by stomach cancers, lung, and the rest. What about surgery? This large study shows you that the incidence of venous thromboembolism in over 20,000 patients was shown that the rate is 3.5% within 30 days of admission. Now, not only that, it negatively impacts the overall survival. Those patients with VTE died earlier, and this p-value was significant. And what is the good news? It can be eminently prevented by thromboprophylaxis if you practice it appropriately. And one more thing, occult cancer is known to occur with unprovoked VTE. It may be the first manifestation of undiagnosed cancer, but people over-investigate these patients. Now, there are enough guidelines to say that in unprovoked VTE in elderly people, you do a limited screen with a good physical examination, good history, basic labs, and do an age and gender specific screening, breast and cervix for ladies, prostate for males, colon for both. And don't go to town and do PET CT in everybody and CT abdomen pelvis, because it does not increase the diagnosis of occult cancer and is not cost effective. The risk factors for developing VT in cancer are patient-related with comorbidities, treatment-related when you use platinum-based or thalidomide or lenalidomide, anti-angiogenesis agents, central venous catheters, I'll be talking about that, immobilized, hospitalized patients. And I've told you the site and type of cancers, I've already told you. Biomarkers, the D-dimer and CRPs are less useful than in other non-cancer patients. So imaging has to be combined with them for diagnosis. The risk assessment for VT, one of the validated model is the Khurana risk score. And the Khurana risk score has shown that if it is more than or equal to 3, you have a risk of thrombosis, and you may you have to give them thromboprophylaxis. And this has been further refined by adding 2 biomarkers, D-dimer and soluble P-selectin. And this increases the sensitivity specificity of the Khurana score for risk assessment of cancer patients. And if you see here, it has been compared with the Vienna and the Protect, which are non-validated scores. And if you have a high score, what does it tell you? If you have a score of more than 3 in the Khurana risk score, it tells you that there'll be more than 7% venous thromboembolism risk by 2.5 months, which tells you a lot. So this is the importance. Myeloma is one of the common malignancies which hematologists treat, and you have the IMPEDE VTE score, which has been validated by the working group. And here they actually have a scoring system. And I've just made a hypothetical score where you're using lenalidomide, you're using darbepoetin, and you're using standard dose dexamethasone in Asians. So the score, if you see, is 4. Because being Asian, he gets -3, 7 - 3, he's 4. But anything more than 3 score is high risk. So you have to give them appropriate anticoagulants, either enoxaparin or the present DUAX. But if it's less than that, you can get away by giving aspirin. These are the various societies for cancer-associated thrombosis. They all have across the board told you that you have to give either LMWH, NOAC or DUAX, and depending on the situation, active cancer, you need to continue with the treatment till the end of cancer cure. I will talk about the duration and how you decide on it a little longer, but anything longer than 3 months is long-term, and beyond 6 months is extended therapy. The treatment of cancer-associated thrombosis, LMWH versus DUAX. These are the famous 4 studies, Hokusai, SELECT-D, ADAM-VT, and the Caravaggio, where edoxaban, rivaroxaban, apixaban have been compared with deltaparin. And what do they find? They found that the lower VT recurrence risk definitely with DUAX as compared to LMWH, which is a very important finding. However, they had a higher bleeding risk in GI and GU cancer with DUAX. This was not known before these trials. Now we know if you identify GI, GU cancers, don't use DUAX. Otherwise, the bleeding risk is comparable nearly. But this was not known before these trials. Now coming to the very important topic of central venous catheters and catheter-related thrombosis. Upper extremity DVT is an important topic today. The advent of high-dose chemotherapy and bone marrow transplant has led to increasing use of central catheters. Pulmonary embolism is high in this group, 15 to 30%. Classical features of DVT are lacking. Compression ultrasound is not useful for centrally placed thrombosis. I told you, you may have to do with venography or MR angio. The recent studies reported doubling of the upper extremity DVT from 2 to 4% to 10% because of the reasons I just told you. And catheters account for nearly 50 to 90% of all the upper limb DVTs. It occurs within 3 months of placement of the catheter. And so CVC is a strong independent risk factor for upper extremity DVT. This is how it occurs. It predisposes to VT and impacts each component of the workhouse triad. It causes stasis, starts hypercoagulability, and also causes endothelial injury and can result in intraluminal clots, can form a fibrin sheath around the catheter, can have a mural thrombus, or can completely block with a venous thrombosis. The commonly used catheters are non-tunneled, temporary ones used by our critical care colleagues, tunnel ones like Hickman, which we use in our transplants, can be kept for months. Then the ports or the chemo ports are used for children and by the medical oncologists and by us also. Then you have the PIC, which is being used by us for our biologics like ATG and also for treating AMLs. And you can see that they have different risk factors. I'll start with the CVAD subtypes. The PIC has the highest frequency of thrombosis, followed and the least is by of the chemo port. The site, the femoral has the highest incidence of thrombosis, least is subclavian. The procedure, multiple insertion attempts, you'll have more chances of thrombosis. And if you have catheter infection, you have more thrombosis. And very importantly, please place the tip at the atriocaval junction. If it's floating in the subclavian or the brachiocephalic, more chance of thrombosis. The lumen, we go for large lumens, you'll have more thrombosis. So triple lumen 6F will have more thrombosis chances than a 4F single lumen. The material, the older catheters are cheaper. The polyethylene, the polyvinyl, more chances than a siliconized. All the various societies have tried, various RCTs have shown there is no point giving routine thromboprophylaxis when you put in a catheter, that's the central catheter. So routine thromboprophylaxis is not recommended. So how do you treat it if a thrombosis occurs? You treat it with anticoagulation, and the anticoagulation can be LMWH, can be NOAC, DOACs, or vitamin K antagonists. Duration is usually 3 months. When you remove a catheter, when infection is clearly demonstrated, defective, no backflow, and you can't push anything. So the catheter is completely blocked. The line is no longer necessary. You put it for a cancer, which is cured now. So it served its purpose. A BMT patient, the BMT is completely successful, and the patient is going home. Then comes to another important topic is the newer oral anticoagulants. For nearly 60 years, ladies and gentlemen, we had only warfarin. It had a narrow therapeutic index, but delayed onset of action and delayed offset, mandatory lab monitoring PT-INR, and drug-to-drug interaction, which are not easy to manage. Then was born the NOAC or DOAC. And this term was introduced for dabigatran in 2010. Thereafter, the next 5 years, up to 2015, 3 more newer anticoagulants were born. So the novelty was lost. So the ACCP, however, in 2016, still stuck to the acronym NOAC. They changed it from novel anticoagulants to non-vitamin K oral anticoagulants. However, the ICH-TH thought differently. They put it to a vote, and 90% responders preferred DOAC over NOAC, and they have stuck to the term of direct oral anticoagulants. However, NOAC and DOACs is still used interchangeably in publications and in presentations. When starting these oral anticoagulants, you must look at the cost, the baseline labs, especially the creatinine and the liver function, the creatinine clearance. If it's less than 30 ml, you have to make modifications. The dosing and the drug-to-drug interactions, very important. All these 4 drugs are FDA approved for atrial fibrillation, VTE, and VTE prevention in orthosurgery. They have short half-lives, and dabigatran is actually 80% excreted by the kidneys, while the others, only a third is excreted by the kidneys. In dosing, dabigatran and apixaban have a PD dosing, the other 2 have OD dosing. Both dabigatran and edoxaban have to be bridged with LMWH for the first 5 to 10 days before they start acting. So you have to couple them with LMWH when you start therapy. These drug-to-drug interactions, you must have a card with you in your soft copy in your mobile, and you must refer to this as often as you can. You can see many of the drugs that you use can reduce the efficacy of DOACs, and many can increase the blood levels and thus can cause toxicity or bleeding. So you must know these drugs. I'm not going to go into each one, but even as common as paracetamol can increase the DOAC levels. The transition between anticoagulants, it's very easy to know that when you do LMWH to DOAC, you just stop the LMWH, and the next dose of when the LMWH was due, you can start the DOAC. Same thing when you want to convert DOAC to LMWH. The issue is when you want to start a VKA like warfarin, then you depend on the INR. Till your INR is between 2 and 3, you'll have to parallelly run both the drugs, whether it's LMWH or DOAC, before you stop either of them and take over into a VKA, which is, we're talking of warfarin. The costs have really become good. You can see the cost. I've just given it for 10 tablets. It's very, very affordable, and multiple companies are making it. And so if you compare it with the West, it is a revolution. So it is no longer, say, unaffordable. It is very much eminently affordable. There was a concern about reversibility. The drugs were not there. Both these drugs are FDA approved, and one is a monoclonal antibody fragment, idarucizumab for dabigatran. Then you have the Net, which is for edoxaban and rivaroxaban, but they are costly and not freely available, obviously. So what are the aims of VTE treatment? The aims are very simple. Prevent local extension of the thrombus, prevent embolization, relieve the symptoms, and prevent vascular occlusion. The long-term goals, as I told you, prevent recurrence, prevent post-thrombotic syndromes, prevent chronic pulmonary arterial hypertension. And for this, when you start any prophylaxis, the bleeding risk has to be balanced with the recurrence risk. And the patient preference cannot be avoided. Does he want injections subcutaneously though, or he prefers oral drugs? Oral drugs, does he want a VKA or a DOAC once a day, twice a day? What are the drug-to-drug interactions? What are his comorbidities? So it's a complex decision. So this balance has to be maintained. And whenever you have a DVT, you have to know what is the risk factor. And the risk factor can be transient, which is major, like in major surgery or trauma, where once the risk is removed, then the low risk of recurrence. And the minor transient are like pregnancy or a long haul flight. And then the unprovoked, where you have idiopathic so-called no identifiable risk factor. This is the worst. They have the highest rate of recurrence. And when you have persistent, for example, cancer, it can take 6 months to 1 year before you can withdraw the anticoagulation. The risk is high. You can go for 3 to 8% of recurrence. And obviously bleeding is also a risk along with that. So the 3 phases of treatment are the initial acute treatment phase, 5 to 21 days, long-term from 3 to 6 months, and extended 3 to 6 months beyond it. And I told you that dabigatran and edoxaban have to be parallelly started off with LMWH for 5 to 10 days before you can withdraw that and go on to only this drug. Sometimes you don't get the VTE continues despite anticoagulation. What do? You check for medical medication adherence. Does he have an APLA? Does he have a underlying cancer? Does he have myeloproliferative disorder? Does he have HIT if you are using heparin? Does he have thrombophilia like antithrombin deficiency, structural defects, or a drug failure itself? You may have to increase the dose of LMWH or a warfarin resistance. So the major therapeutic advances, which I've told you, is firstly, nowadays, GCS, or graduated compression stockings, are no longer used to prevent PTS. It can be used only for symptom relief. And I also told you for recurrent VTE, males behave differently than females. You can use the Hurdu model for females, which I'll come to later, to exclude the recurrence risk in females, but not for males. Males have a very high risk of recurrence. And then DOACs are non-inferior to oral anticoagulants like warfarin, and they are also non-inferior to LMWH and cancer patient. So I have told you this. And then I just want to say that catheter-directed thrombolysis, the ATTRACT trial has shown no advantage. And IVC filters are only used when there's an absolute contraindication, hardly used in India, but in the West it is still used. And insufficient data to support the use of DOACs for APLA, for HIT, and for unusual sites like splanchnic vein thrombosis. Now coming to one of my favorite topics, the high altitude thrombosis. We clot very frequently. We don't know the reason. So can we unravel the plot behind the clot? So this is a landscape that looks picturesque, inviting you for a holiday. This can change within hours into a treacherous condition. And this is where our soldiers stay. And when they are cut off from the mainland, helicopter is the only way you can get them out. And when they are sick, they sit like this. And you have to get them onto a helicopter, which just comes for minutes to take them, because they really can't halt there. We're talking -20 to -30 degrees temperature outside. High altitude is defined as above 8,000 by the scientific definition. In the army, we take it about 9,000. Extreme high altitude is more than 18,000. What are the peculiarities of thrombosis at high altitude? Firstly, it affects young, healthy subjects. Highland natives are hardly affected. The incidence increases as you go higher. More than 16,000 feet, it greatly increases, as you will see. Usually, it occurs within weeks or months of stay, and it occurs in unusual states, unusual sites in the brain, splanchnic circulation, and dehydration, forced inactivity, and bulky constricted clothing doesn't help. And today, high altitude is being used for extremely large number of reasons, for sporting activities, for research activities, for travel. This is the Lhasa rail in Tibet. On the extreme top left is our soldiers, and this is on our Pakistan border and our Chinese border. We have the eastern and western Himalayas. That's where we did certain researches. And I started my research in the Lahaul Spiti Valley when I was a lieutenant in 1979. And we doctors are taught how to fire. We are all holding 10 guns here. So we call ourselves doctor soldiers. And thereafter, this thrombosis has been part of my journey till I retired. And to date, I carry on. This is the first case vignette. This officer, a teetotaler, doesn't drink or doesn't smoke, was posted at 19,000 feet at the Sonam post. He developed pain abdomen, stroke in the brain, became unconscious, managed by the medics, couldn't be evacuated for 11 days. There was a blizzard because the helicopters couldn't land. They at last evacuated him. They brought him to Army Hospital via Chandigarh. In the Army Hospital, we found a 34-year-old man who developed disseminated intra-arterial and venous thrombosis following exposure to extreme high altitude. On evaluation, the patient was found to have thrombosis involving the aorta, bilateral iliac arteries, and middle cerebral artery. On detailed evaluation for the cause of recurrent seizures, he was found to have cerebral venous thrombosis. Procoagulant workup took us years, but it revealed increased pi1 activity with 4G/G homozygous polymorphism. This case highlights the life-threatening and limb-threatening thrombosis secondary to a rare inherited thrombophilia in an otherwise perfectly fit soldier. We published the PMJ case reports. But we didn't give up. We supported him, anticoagulated him, and it took us months, but he regained his consciousness. He recanalized in the brain all those clotted sinuses and the portal circulation. But we had to amputate 3 limbs, and it took us months to do this. He got very disturbed, but ultimately we got him to understand and he accepted it. And today, I'm happy to tell you, he's posted in Pune. We got 3 robotic limbs and he's doing extremely well. He lives there with his family. This next patient is in the Eastern Himalayas. Very early, I was in Calcutta. A 35-year-old healthy male with no history of any past medical illness developed severe headache, vomiting, and drowsiness while at high altitude. In the Eastern Himalayas, he was evacuated to a tertiary care hospital where he was diagnosed to have CSVT thrombosis on MRI and DVT of his right lower limb. Investigation showed us protein S deficiency. Family screening was also positive for protein S deficiency. He later on improved. This whole superior septal sinus was blocked. It took 6 months from June to December. He recanalized, became fit, but obviously he could never go back to high altitude. Then we published symptomatic portal system thrombosis in soldiers due to extended stay at extreme altitude. And they found that this group of 26 patients had 80% no thrombophilic reason to get clotted. So only high altitude was the risk factor. While in the plains, it was not so. Only 30% had no risk factor. The others all had some risk factor. So high altitude was the risk factor. So we said, let's address this. And for that, we reviewed all the existing data. Majority of the data published in the world comes from our Indian Army and in good journals, from Circulation to Lancet to PMJ. And we continued publishing case reports and case series. And we just found that let us do a study to see what the epidemiology of these disorders at high and extreme high altitude amongst the soldiers, a longitudinal study, the first of its kind in the world. And we did this in 4 phases. I coordinated the study from Army Hospital and AFMC Pune. Command Hospital Chandigarh was also involved, Military Hospital Jammu. So multi-centric study, and field hospitals in Ladakh, Tansei, and Pratapur were also involved. And these are the phases we did it. At sea level in Jammu, all the soldiers are screened by us. And after screening, we did a clinical radiological lab screening and also looked for DVT and ultrasound Doppler were done. And these were the tests done, all detailed biochemistry, coags, and the DRDO helped us with endothelial markers, biomarkers, inflammatory cytokines, and also a representative sample for proteomics and genomics. And we found that 16 patients were unfit because of the reasons shown here, were taken out from the group to go to the glacier. And then we went to Tangse, which is around 15,000 feet, prefabricated huts, centrally heated, where we actually examined all these patients after acclimatization. They did well, there was no problem. This is with the ECC clothing, which they wear to go to the glacier. And we obviously had a good lab working there. And we collected all the samples at various time points at the base camp to the sighting glacier. And then we also collected once they came back. They are centrally heated, the outside temperature is -20. And we obviously collect the samples here. You can see on the right bottom, see the varicose tree or the veins. This man had DVT. So all the collaterals stand out. And this patient's then, this is what it is outside. This is how the soldiers live. On the snowmobiles, we move around. These are the crevices where if you fall, death waits you. But this is how they live. And the heights are from 15 to 20,000 feet. Our team, I had a team of nearly 20 people. We used to go there every 3 months to do this study. And ladies and gentlemen, it was the most rewarding study that I've done in my whole career. Despite all this, we found that 15 people still got thrombosis. 7 got CVT, 2 got DVT, 1 got DVT, CVT, 2 got DVT and pulmonary embolism, 2 got peripheral arterial obstructive disease, and 1 stroke. So the salient features it's under publication, was hypercoagulable state, endothelial dysfunction was there, increased inflammatory markers, there was dampened fibrinolysis, and EHA, extreme high altitude, was an independent risk factor, we thought. We also had our fun doing this because it's otherwise very monotonous just to do the risk. Every trip at 4 time points, this is the number of samples we carried back to Delhi. We had -20 degrees, which we could actually do for transportation. These are some of my teams which helped us do the study. I can't finish this talk without talking of COVID. COVID-19 and thrombosis has been talked about amply. I just have a few slides. COVID-19 can affect both large and small vessels. That's about high altitude. Now this is COVID can affect large and small vessels. And you must ensure that all patient risk are assessed for VT and for the bleeding risk, and appropriate thromboprophylaxis should be given for the weight and also check out the renal function with a high index of clinical suspicion. Now, these are the 10 vaccines which were launched by and approved by the WHO for use for COVID-19 globally. Now, the last 3 are adenovirus R is the vector. And this is actually the Johnson & Johnson, the AstraZeneca, and the Serum Institute Covishield. All these use the same adenoviral vector-based vaccines, and they've been implicated in VITT. And these are the 2 vectors that we use. What is the incidence? Not fully known. It can be 1 in 30 to 100,000. Case fatality rate to the tune of 50 to start off with. Now we are talking of, in single digits, because the measures have been taken so fast to address it, to learn about it, to educate people about it, the doctors, the healthcare workers, the patients. So this is very, very important for us to know. And this is the model in which we actually diagnose it. These are the 5 criteria for definite vaccine-induced thrombotic thrombocytopenia. And, you have, one is the symptom between 5 to 30 days of the vaccination, documented thrombosis or severe persistent headache, thrombocytopenia, raised D-dimer, and positive ELISA for PF4 antibodies. All the 5 criteria there is definite, or it can be probable or possible if other criteria are missing. Accordingly, you have to give anticoagulation and IVIG, and you can effectively treat them. And if you pick them up early, it can be much better outcome than what was reported earlier. And this should be differentiated from HIT and from the pneumonia. The immunothrombosis is different in the 3. And it's beautifully given in this article on autoimmunity, because in one, it is the PF4 heparin in HIT, and it is the PF4 with the double-stranded DNA forming the complex. That is the endovascular PF4 binding to the microbes and the viral DNA with the PF4 complexes. And while in HIT, it is the heparin PF4 complexes, while in the pneumonia immunothrombosis in COVID is the RNA itself which causes it. So these three basic differences have to be understood. The treatment besides anticoagulation is to understand what anticoagulants you can use. The anticoagulation is now these are the fundamental advances in VIT. The anticoagulation is the first pillar, and the safe anticoagulants are oral and parenteral, direct thrombin inhibitors, oral factor 10 inhibitors, and fordaparinux. We avoid heparin. And why do you avoid heparin? Is the bullet here. That is because 5% of these patients have cross-reacting antibodies with PF4 heparin complexes, wherein if you give heparin, it may worsen, but it's only in 5%. So when you don't have any other choice in a poor country with other drugs are not available, it's better to give heparin than not. Don't give anything, because the chances of his thrombosis will be much worse than this actually being caused, because it's only 5%. Then you may have to give IVIG, 1 gram per kg, and if it's a very serious situation, you may give it over 2 days. And thrombocytopenia itself is not a contraindication to give anticoagulation. And optimal duration is likely to be similar to non-VITT thrombosis, that means nearly 3 to 6 months. And the antibodies can remain for 5 to 6 months. And an increase in D-dimer without any other explanation indicates ongoing clotting. This is just for VITT I'm talking. And the therapies to be avoided in VITT is, one is oral anticoagulants like warfarin must be avoided. They can cause protein C deficiency and worsen the hypocoagulable state. VKA may be considered in subacute period once the platelet counts are normalized. Aspirin must be avoided because it increases the bleeding risk. Platelet transfusions are best avoided, but in life-threatening situations, you may use it. And the strategies around the vaccination, the message is vaccinate, vaccinate, and vaccinate. The second vaccine, if you have the luxury in patients, should ideally be an mRNA vaccine, but if you can't, you take the precautions and go ahead, because VITT appears to be almost exclusively a first dose problem. So you have educated the people, and obviously you may use like, a likely inactivated virus like Covaxin in a Covishield situation may be worth trying. But obviously we need evidence, we need trials for this. The Surgeon General, the last few slides, the Surgeon General has called to attention. I'm talking of the summing up my VTE talk now. The Surgeon General has said all stakeholders must do everything to prevent DVT and PE. And in our country and the world over, the insurance agencies have not waited. They have said that proposal that VTE, which occurs in 30 days of admission, should be prevented, and we may not pay you, we may not reimburse you, and they are making guidelines for it. So we have to be on board. And the awareness has to be spread from 2020s, has been a growing public health interest, and we have to educate them and the doctors and the healthcare providers alike. And we must have DVT-free hospitals. We must have a DVT or thrombosis awareness day, must be adopted, like Congress in the US have done it. So we must do that. And we must know that Medicare has declared DVT and PEs now as never events and will not reimburse. So we must be aware of this. And so obviously prevention is better than cure, no doubt. There's no debate on this. And with that, ladies and gentlemen, I have gone a little fast through COVID and VITT, but the rest I went as slow as I could. I end my talk and I would hand over back to Dr. Agarwal for any discussions, questions on this topic. Thank you very much for a patient audience.
Thank you so much, Lieutenant General Velu Nair. Masterly presentation and fantastic personal experience. What a presentation, what a piece of work you have been doing, and sharing this, all the experience that you've had in this field with all of us. We'll give you a rest for 5 minutes, during which we will just answer the quiz which we had asked the PGs, and then go back to you and give you again with Q&A session for half an hour.
Thank you, sir.
Thank you. So I'll just share my screen. So we come to the Sunday pictorial quiz that was asked, and those of you who were there at that time, we showed you this picture. And we told you that there are 3 diseases at the bottom. All of these are immune-mediated diseases. Autoimmune hemolytic anemia, where antibodies are damaging the red cell. Microangiopathy, antibody to the ADAMTS leading to TTP. And acquired hemophilia, where there are antibodies against factor 8. And the source of this is from lymphocytes and the plasma cell, the B lymphocyte and the plasma cells. One of the drugs that has been used in the treatment of all these 3 diseases, autoimmune hemolytic anemia, TTP, and acquired hemophilia, is rituximab. And it's used because it works at the level of B lymphocyte. It is anti-CD20 antibody. So that's something very simple. And we have put a question mark here with arrow both onto the B lymphocyte and onto the plasma cell. And we wanted you to tell us what this arrow, what this question mark signifies. What is the most appropriate answer to replace this question mark? Something that works on B lymphocyte, the plasma cell, and something that is effective in autoimmune hemolytic anemia, TTP, and acquired hemophilia. So that was the puzzle or the question. Well, these are the replies we received. 40-45 people have answered, and these are the various replies we received. First of all, coming at the bottom, the replies received were here, TTP and MAHA. Now that was probably totally misunderstood question. TTP is the disease. MAHA is the sort of mechanism or the disease. So obviously that cannot be at the question mark. So thrombotic thrombocytopenic purpura, microangiopathic hemolytic anemia is absolutely out of the box. Then we received 4 drugs. Daratumumab, 5 drugs, daratumumab, steroids, caplacizumab, eculizumab, and bortezomib as the answer to this question mark. I'll discuss this because a part of this quiz is to educate the postgraduate students. Daratumumab, as you know, is anti-CD38 monoclonal antibody. CD38 is on the plasma cell. Daratumumab works in plasma cell dyscrasias, various types of diseases. There's some data that daratumumab works on T lymphocytes because that has CD38 and it has been used for T lymphoblastic leukemia as well. But daratumumab does not work on B lymphocytes. And daratumumab has, anyway, we'll not go into the controversial issue, but that's the main thing, that the daratumumab, which is the answer given by 75% of those who have answered. It is not a correct answer because it is not a drug which works on the B lymphocytes. I will leave steroid for the moment and come to caplacizumab. Caplacizumab is a drug which is used for TTP. It is not used for autoimmune hemolytic anemia. It is not used for acquired hemophilia. Caplacizumab is a anti-von Willebrand factor nano antibody. So it interferes with the interaction between von Willebrand factor and the platelet. So obviously it has nothing to do with this particular picture that has been talked, nothing to do with this question mark. Okay, so it has nothing to do with plasma cell, nothing to do with the B lymphocyte. It is anti-von Willebrand factor nano antibody. Eculizumab similarly has something to do with the complement. It's an anti-complement antibody. Once again, it does not fit in the scheme of the things over here. So what does that leave us with? Steroids and bortezomib. Now this, I understand, was a bit confusing. Steroids work in all these 3 diseases. Bortezomib also works in all these 3 diseases. So there are people who have answered steroids. There are people who have answered bortezomib. There are people who have answered both, which obviously is not acceptable. The correct answer was bortezomib. We know bortezomib and its role as a proteasome inhibitor in plasma cell dyscrasia, and that doesn't require any discussion. Bortezomib is a very powerful drug acting on B lymphocytes by its proteasome inhibitor, NF-kappa B pathway. And that's how bortezomib has been used in many, many lymphomas. You know its role in mantle cell lymphoma. You know the trials failed, but it was used in DLBCL and so on. So bortezomib, B lymphocytes and plasma cell is effective. I can't take too much time, but this was one experimental study in mice where bortezomib injection has been shown that how it decreases the absolute cell numbers of lymphocytes, T T lymphocytes, the thymocytes, the bone marrow, B cells, and the splenocytes. So bortezomib is effective on B lymphocytes. That's how it is used for various types of lymphomas. Now we got three answers which are close to what can be considered as correct. One is absolutely correct, that I will show you a little later on. Two of you, Dr. Mukul Agarwal and Dr. Ankit Jitani, did answer bortezomib. But Dr. Mukul Agarwal, after a while, sent another reply that the answer is steroid. And it's understandable why steroid would appear appropriate, and that's why that explanation which I gave you. While Dr. Ankit Jitani has put two answers in the same reply, bortezomib and daratumumab, and daratumumab is not an acceptable answer. So I'm not able to give the prize to Mukul Agarwal and Ankit Jitani. So fastest finger fast winner who gave only bortezomib as the answer was just one, and that is Dr. Gunjan Prasad. By now, everybody knows Dr. Gunjan Prasad. She has already won a number of prizes in past. She has attempted each and every quiz, I would say. She is, to the best of my information, senior resident doing DNB in clinical hematology, in Department of Clinical Hematology, Apollo Hospital, Kolkata. And if you have finished your DMT and now you are a faculty there, then please pardon me this introduction. So congratulations to Dr. Gunjan Prasad. Your prize will reach you. Thank you so much. We now come to the Q&A session. So we have some questions in the question box from the audience, and we already have raise hand sign. We will be using raise hand sign as far as the participants over here are concerned, in the order in which you put up your hand. So Sharad Damodar, your question.
Good afternoon, sir. A wonderful talk again with all your experiences. It was really nice to hear it. So just a thought, what are your thoughts on the use of DOACs in the APLA syndrome, sir? Because kind of people have been using, that's why.
So, the evidence is thin on APLA. So, we have to, if you go by evidence, people off-label use it for multiple purposes, but presently it is not cleared, it has not entered the guidelines. But so we stick to the conventional things, especially when there's severe APLA. APLA, which is mild when you get away with aspirin. I'm talking of APLA, when you have a catastrophic APLA, you have to be very, very careful. So the severe APLAs, I will not yet use DOACs because the data is thin. I will still go for what we've been practicing in terms of heparin, LMWH, and switching to VKAs along with steroids and IVIG.
Right. Thank you, sir. Thanks.
Thank you, Sharad. We'll take one question from the audience. When you do splenectomy, you will end up with portal vein thrombosis in some patients. In this situation, will you use anticoagulants?
So this is again a very practical question. When you do splenectomy, obviously you have underlying disorder for it. So was it hematological or was it not hematological? You do splenectomy in a splenic trauma and a splenic rupture, also you do a splenectomy. But people in the earlier years for thal intermedias and the other hematological disorders where transfusion dependency became very heavy, they used to do splenectomy. We know that. So in that, the approaches, two approaches are different. For me, a thalassaemic syndrome is already thrombogenic. He already has an underlying tendency for thrombosis. While a rupture spleen after a road traffic accident, when you remove the spleen, will also have thrombocytosis. But this will be short and it will come down much faster. And usually it's, less than 1 million, but definitely you will find that it is short-lived. So you support and wait and watch. Underlying cause is very important. Why? If it's a thalassaemic, patient who's 25, 30 years old, for transfusion purposes, he's undergone in a government hospital, he's undergone splenectomy. And they have found that he's got very high counts of platelets. This, I will look at it differently. Because here, an older patient with the underlying diseases, I will give him thromboprophylaxis and withdraw it as and when the reactive thrombocytosis settles down. This may take weeks. We usually wait for 2 weeks to 4 weeks. By and large, they all come back. But I will afford thromboprophylaxis at this juncture. Especially, I will apply the risk model. What are his risk factors, which I showed you? And he will fit into the risk factor where you need to give him thromboprophylaxis. And I would certainly do that until the platelet counts normalize. then I will actually withdraw it over a period of week to 2 weeks.
Right, Dr. Velu. The second part of the question is, if the patient develops portal vein thrombosis, will you treat this with anticoagulant?
So this is a very good question and not talked about very often in our gatherings. The portal vein thrombosis can be in an acute setting and can be in a chronic setting. In the acute setting, it can be a portal vein thrombosis, it can be a splenic vein, or it can be a mesenteric vein. All these can come with acute or chronic. In the acute, there's no doubt you rule out the bleeding risk and you actually give one of the conventional anticoagulants. We still don't use DOACs here. We are using the conventional anticoagulants. And you must use it. And in the meantime, you're investigating the patient because this may be the first time you're seeing the patient. So ruling out a bleeding disorder or a liver dysfunction is very, very important. And obviously, if it becomes chronic, then you may have to put him on longer term and you will change over to an oral, and vitamin K antagonist is the commonly used. The guidelines are not available very commonly in ours, but if you go to the American College of Gastroenterology, they have actually made the guidelines for this, and they have very clearly said that in acute and chronic settings, you can use the anticoagulation, which I just told you.
Thank you. This is an interactive session. Please feel free to add your experiences, all of you. Whatever you want to do or you want to answer differently, please feel free, because that is the best way to educate our postgraduates. Now, Dr. Mukul Agarwal, your question.
Thank you, sir, for an excellent talk. My question is regarding choosing the DOAC for a patient. For cancer-associated DVT, we are commonly using rivaroxaban or apixaban, but there is not much data or trials with dabigatran. Similarly, I just have a feeling that dabigatran is somehow less popular with hematologists and more popular with cardiologists and maybe neurologists as well. So any particular reasons for these?
It's just usage. You're very right. Dabigatran has become classified as a cardiologist drug. So many of the cardiology patients who we share with hematology, they are already on dabigatran because the cardiology already started. So I don't think it's got enough attention. And the other thing is, remember one thing, comorbidities. Our patients, for example, a myeloma patient, renal dysfunction is very common. In our myeloma patient, there's a comorbidity. 80% of dabigatran goes through the kidney, and 30% of the rest is kidney excretion. So dabigatran has got an issue there. And so, there are certain black box warnings for dabigatran, but definitely I don't see any reason why it cannot be tried. I have seen a lot of people actually using it, but the trials are thin on data here. The other 4 which I showed you are the published data, but the jury is still out on this. So I don't think the final word is said that which one will each one of us use in the years to come.
Yes. Thank you.
Thank you, Dr. Mukul. One more question from the audience. In acute pulmonary embolism, do you give both heparin and DOACs, or can we use DOACs alone?
So, we have not dealt with acute pulmonary embolism today. So, you have to risk stratify, and after that, if he's a massive or a submassive. If it's a massive pulmonary embolism with a hemodynamic compromise, it's all settled. You have to end up with giving a thrombolytic agent. And with the thrombolytic agent, you give actually an anticoagulant, and that usually is heparin. And obviously, here comes in the role of LMWH versus unfractionated in a massive pulmonary embolism with hemodynamic compromise and right ventricular dysfunction. Then you come to the other categories up to the sub-segmental, where you may not even give, you may just follow up. And in that comes in the role of oral anticoagulants or wait and watch. When you have actually categorized him on what risk he comes into. But obviously, all anticoagulants have been tried depending on the risk. If it is minimal, like I told you, subsegmental pulmonary embolism, one segment involved, the ACCP guidelines and others say, wait and watch, follow up, do D-dimers, follow up, but they don't repeatedly do a CT angio.
Thank you. Dr. Akanksha, your question.
Good afternoon, sir. Thank you for the phenomenal talk. So I had a question regarding once after the extension phase, after that, is there any role of tapering the anticoagulation or just stop the anticoagulation abruptly? And is there any means of monitoring these patients post stopping the anticoagulation?
I think it's the most practical and the most difficult question. The reason why I say difficult is because this is a practical problem we face, especially in long term. Talk of cancer. In cancer, we know that VT can become recurrent. And the moment it becomes recurrent, it becomes a much bigger problem to manage to prevent the next recurrence. So you must see what is the residual venous thrombosis. And for this, you need imaging expertise. And you use the tool called D-dimer. So, like I told you, in active cancer, it may not be such a big role, but in follow-up, when cancer is being treated and the patient is in remission, yes, it has a role. So you find a D-dimer which is settled down, starts rising again. I have a problem here. I must look at it very closely because I know that there will be residual organized thrombus, and what is the residual active venous thrombosis is not easy to make out. So the compressible venous segments, an expert, you must have the old photographs of your compression ultrasonography, the films, and it's good to be in touch with your own radiologist because they really help you. The coupling these two helps us know there is something ongoing right down there. So D-dimer is useful, clinical symptoms is useful, and then obviously you will end up with again an imaging to see, to confirm what you have done. And if he's got a rising D-dimer, I won't dare to. That's why we say indefinite long-term anticoagulation. But in a lady where you have the HER2 rule, where you want to withdraw, the recurrence risk is much lower. It's less than 3% in the first year. And where you can actually venture into say, can I withdraw my anticoagulation? Answer is yes. How do I do that? I must again risk stratify as per the HER2, and the score is, you look for the evidence of post-thrombotic syndrome, the D-dimer level less than 250. And, like there are 4 such things: older age, body mass index. If all those score is 0 or 1 or lesser, the risk of recurrent VT is negligible. And if it's negligible, you can remove the anticoagulants and wait and watch and follow up with good health education to the patient. This cannot be done in males. The risk in males for recurrence is the tune of 3 to 9%. So this HER2, when the trial was done for validation of the model, there were no males there were no male patients because nobody has less than 3%. So males are cursed here. So unfortunately, everywhere I say, this is one of the places where males don't figure in the model itself. So here you can, and tapering, really speaking, over 1 month, 2 months doesn't make sense. So if you have everything else is negative, D-dimer is settled, patient is asymptomatic, cancer is cured, you give it for 6 months, and you are welcome to remove the whole anticoagulant. I generally do it over a week, 10 days, and then just keep it under follow-up, call it after withdrawing after another 10 days. So all is fine, keep it under follow-up. But there's no very clear guidelines to say how many days, 10 days or 2 weeks or 4 weeks. It all depends on the condition for which you gave the long term. Okay, like if it's a thrombophilic situation, antithrombin 3 deficiency, recurrent VTE, recurrent VT, family history, unusual sites like the cerebral sinuses, I will give lifelong. But don't forget, there is a risk of bleeding every year, which increases with age. So that's real. So you must not forget that these patients have been told, you get a peptic ulcer, come back to me. You have to undergo surgery, come back to me. You have a road traffic accident, come back to us or consult us. And he must carry a card with all that he's doing. So that wherever he can't always be with you, he may be traveling. So the information must be with him. That what anticoagulant is he on? What is his blood group? What should be reversed? There should be a small patient card we give in the army.
Okay. Thank you so much.
Thank you, Dr. Akanksha. Another question from the audience. So there are recommendations about giving prophylaxis for patient to prevent cancer-induced thrombosis. This is valid only for hospitalized patients or even if the chemotherapy is being given in outdoor setting?
Yes, this is a very good question. I had shown you 2 slides on the Khurana risk assessment score. I had shown you 2. This is for ambulatory OPD patients only, validated, the only validated model. The Protect and the Vienna are also there, but this is the only model which is validated. And if you have 2 or more, you have a risk of thrombosis. And I showed you the variables which you take into consideration. And this risk assessment is not a one-time job. It is a dynamic job. So every visit, your nurse should be taught how to do a risk assessment. You must have a scoring system by which every OPD before the patient comes to you, Your residents should know it. Your nurses should know it. So in every visit, some new development has occurred. The score can change. So what was not there yesterday can be there today for you to start. So where we go wrong in the OPD is we lose track. In a heavy OPD, the patient comes, takes his pills and goes home, but he's got a swelling in the leg, which he has not told anybody. So that's why in the OPD, in an ambulatory patient, though he's asymptomatic, you must have a questionnaire. And the questionnaire really helps to risk stratify, and in that will come out. If it's totally asymptomatic, then you go by the risk assessment model. If he's got more than 2 score there, I will still start him on a oral anticoagulant. If he's got more than 3, definitely I will give him an oral anticoagulant and keep him under monitoring.
Thank you. Professor Chandrakala, your question.
Thank you, sir, for a wonderful lecture. And sir, regarding the catheter-directed thrombolysis in a DVT patient, because actually NEGM published that it's not a role, because still the post-thrombotic syndrome is a major problem. It's the DVT, and the post-thrombotic syndrome causes loss of work also, some patients. So how should we use, whether it is really useful or it is equivalent to anticoagulation, oral anticoagulation?
I think, again, a practical question. It depends actually where we practice. The vascular surgeons and the interventional radiologists are the ones who do this for you. Okay. So, and you have to give a thrombolytic agent. So firstly, you must rule out any contraindication for thrombolysis. Number 2, the NEGM paper and publication thereafter shown, it was primarily said that does it decrease the frequency of a PTS, a post-thrombotic syndrome. Now that gray area has obviously been proved not to be so. So it is no longer given to decrease the frequency of post-thrombotic syndrome. However, I told you one of the acute complications is venous gangrene. And let me tell you, it occurs. We have seen patients of venous gangrene when you lose a limb. The limb is gone, gangrene, and it's terrible. I showed you the pictures. So in that situation, I certainly will give thrombolysis. I will definitely, this is one situation where your vascular surgeons, if they are confident, you must give CDT, catheter-directed thrombolysis. But be very careful because lytic agents can cause bleeding. Remember that. We've had a patient where aggressively it was given by the surgeons and he came with torrential GI hemorrhage. He had a silent peptic ulcer lying inside. He came with torrential bleeding, Luckily he survived, but these are situations before you do it, you must make all the effort to rule out a bleeding diathesis, which I feel is not being done adequately. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Chandrakala. Another question from audience. So there is a patient with unprovoked proximal DVT. He is on warfarin. His INR is properly maintained in the target range. However, he still gets a recurrent DVT. How will you manage this patient further?
So this is again a very practical question. I showed you 2 slides on this. I said that when does VT recur or occur while you are on anticoagulation? This is that situation. So have you ruled out an HAPLA, underlying HAPLA? And very often it is not. Have you ruled out an underlying thrombophilic situation in a young patient who's come with recurrent VT in an unusual situation for which you're giving the VK, the warfarin? So you have to rule out these things. Does he have a structural problem in his limbs somewhere which is predisposing him to thrombosis? Does he have warfarin resistance? Because there is a warfarin reductase enzyme mutation which makes them resistant to warfarin. And in these cases, sometimes mild resistance can be overcome by increasing the dose. And sometimes we've had to go, if 5 works, 10 works, sometimes you're giving 15 to 20 milligrams. So there are patients who may require much higher dose to get the INR, but be very careful when the INR can run away from you. So be very careful or shift them, change them to heparin or one of the other agents which I've discussed. But these are the causes which you must look for recurrence of occurring while your INR is maintained adequately and you're still getting an occurrence. These are the common causes.
Right. So, doctor, the answer to your question was in the last sentence of Dr. Velu Nair, that there was no cause found and the INR was in the therapeutic range and still the patient got DVT. And as he mentioned, then you have to switch it over to heparin. Dr. Satish, your question.
So thank you for that very comprehensive talk and that exemplary study of thrombosis in high altitude. Very, very interesting, and I can understand how much trouble your team would have taken. So I have a couple of questions. You have already partially answered them, especially in unprovoked DVT. I understood that in specific situations, we need to, it's not an easy thing to decide whom to stop. We have to be patient oriented, but in a non-cancerous situation, unprovoked proximal DVT after 6 months, thrombophilia workup is negative, D-dimer is normal, ultrasound shows reasonable resolution of the thrombosis. Okay, say male patient. So the risk of recurrence is 3 to 8%. How do you approach, sir? How do we counsel the patient that there is this significant risk of 3 to 8%, it can recur and you need lifelong anticoagulation? How do you take the decision and how do you counsel the patient, sir?
Again, practical question. You know, here you have to sit down with the patient. Firstly, you have got an idiopathic, unprovoked proximal DVT is what we are talking about. And you have ruled out any other things like which you just said, thrombophilia or any other secondary cause. That's why it's idiopathic. And here, the age of the patient, I told you, suppose it's an Indian patient who's less than 45 years of age, my approach will be different. If he's an older middle age or a patient who's 50, 60 years old, it will be slightly different. As we know, in the older age group, malignancies are, occur commonly. And I told you that there is a 3 to 5% chances or even higher the whole year when you follow up these patients, the old age group, a occult malignancy surfaces suddenly. And I told you that how much must you look for an occult malignancy. You should not overdo. So I will advise him. Like an older patient, I will say, okay, if you're a smoker, if you get cough, if you get hemoptysis, come back to us. In bowel, if you have alteration in bowel habits, please come back to us. If you have melena or fresh bleeding PR, please come back to us. If you have hematuria or gross hematuria or any genitourinary complaints, please come back to us. So you must educate him on the possibilities of a malignancy coming up. Or it could be just the bleed because the anticoagulation is stopping. He should have no reason to bleed after stopping anticoagulation. After 6 months, you've stopped it, and he's coming to you after 1 month saying, doctor, I'm having hematuria. Doctor, I'm having fresh bleeding PR. Doctor, I had constipation, which was not there before. So all these warrants a search. So a search for a malignancy which comes up, you must look for it. That is one. And the second thing is, how frequently should you see him? It again depends on the education of the patient. If he's coming from a village, who's uneducated, who only understands very basic things, I have to make sure that he comes back to me. So if I say come back monthly for the first 3 months, I'll be a happy man. But an educated person, same city, he's living where you are. A telephone consultation will tell you after 1 month, I'm fine, doctor. These are my reports. I've seen the reports. I've given him a teleconsult. I am fine. I'll call him if he develops anything. So it cannot be homogeneous for each patient, not the same. Right. It is, you have to individualize it as per patient needs, but I've given you a flavor of how to do it. So, you have to keep him under monitoring. You have to keep him under close monitoring. And last but not the least, in a certain percentage of this idiopathic proximal, the DVT can come in the contralateral limb. Suddenly, he has taken care of the right lower limb. You have treated it. No PTS, you've done a good job. And now suddenly he's a health freak, he's walking and he finds that he's getting cramps on the other limb. And he comes back with a swelling next day to you. Contralateral DVT. It is well known. It's a much higher incidence once you have idiopathic proximal DVT to develop contralateral and ipsilateral recurrence. This also you must brief. That if you have fresh swelling, fresh pain, fresh redness, you must come back to me. This could be another DVT which has come up. And that could be called a recurrent DVT. So you must know about recurrent DVT. Then you also must know about what you should not take. He cannot keep taking NSAIDs, aspirin as he likes, because I have pain and I go to a surgeon and I get NSAIDs. So NSAIDs, while I'm taking anticoagulants, will compound my bleeding risk. So when I've stopped it, then there's no problem. When I'm on anticoagulants, NSAIDs, he has to know that it is a problem. So there are a lot of talking to be done. That's why there are DVT clinics now. So that's the way to go. Ultimately, have DVT clinics. That's the way to go.
Right. Thank you, sir.
And for PTS, get your vascular surgeons on board. Like in the army, because nobody steals anybody's practice, so it is ideal practice. So all my patients are seen by my vascular surgeon in the beginning only saying, okay, partner, there's no PTS now. You can see. Do you want me to do anything more? Do you want me to do any more scorings? Will you also see him once a month? Yes, sir, he will. So you can generate a lot of data. You can do trials in a if you have your colleagues with you in the DVT clinics.
Yes, thank you, sir.
Dr. Satish, I'd just like to quote one statement by Dr. Sweep Award, whose articles Dr. Velu Nair showed today. She said, never tell a patient that you require lifelong anticoagulation.
Yes.
Tell them you require long-term anticoagulation.
Yes, sir.
Because of exactly what Dr. Velu said, tomorrow, you yourself may tell the patient that now it is more hazardous for you to continue anticoagulation than
Yes,
to
sir.
stop it.
I completely agree. I usually document long-term only. Initially, I was writing lifelong. Now I term long-term anticoagulation.
Very good. Very good. Very good.
So we'll go to one more question from the audience. Do you do follow-up Dopplers in patients of DVT? And if you do, and if you find residual thrombi not fully recanalized, does it affect your treatment, duration, intensity, etc.?
Yes, again, a practical question. You see, we must minimize the cost. Don't forget, this is a chronic problem. And you must know the affordability of the patient. So doing repeated imaging is not possible. Yes, if your symptoms warranted, 100%. And you said that a repeat ultrasonography has shown residual venous thrombosis. If it's a residual venous thrombosis called as RVT, you'll also have D-dimers which are high. And there are likely to be some symptoms, but not all patients have symptoms. But a residual will have reflux, will have incompetent veins. So mild swelling starts creeping in. And when you actually look for it, small varicosities start coming up. So really speaking, a good clinical examination, good history taking, and a D-dimer test I certainly will do. If that is normal, I'll follow it up depending on how much you can afford and the risk factor for which the first DVT occurred. If it was a malignancy, I will be much more active. If it was a non-cancer situation, post-trauma, or a reversible risk factor, I won't really be worried. I will follow up and not do a repeat ultrasound frequently, but certainly do a D-dimer after 1 month and see, and tell him if the symptoms worsen, he must come back.
Thank you. Dr. Radhika, somebody very wisely said, if you do a test, you must act on it if the results are different. So if you do a follow-up Doppler, and then if you find all these things, and now if you don't impact your treatment, then you are answerable to the question, why did you do it? So Dr. Velu very nicely told you, don't unnecessarily keep doing it if you are not going to change your decision.
Yes. Thank you, sir.
Dr. Srimati Shetty, your question.
I can't hear you, Dr. Srimati. Nice to see you. I can't hear you. You're not audible. Put off your mute button. I can't hear you.
No, she's not muted. Some other problem. Srimati will come back to you. Dr. Ashish.
You can put your question in the chat box otherwise. Yes.
Ashish.
Yes, Ashish. Good morning.
Good morning, sir. It's always a pleasure listening to you. Two questions. One is, what is the choice of DOACs that you will use in a CVT? As of now, only dabigatran is approved. So do you use dabigatran alone, or do you try other DOACs also? And the second question is, does the type of hereditary thrombophilia affect the choice of DOACs that you are going to use?
The first question, we have patients of the nature what you're saying. We use only dabigatran. I haven't gone beyond that because we have the neuro people along with us and treating those patients, and we are using dabigatran. We have patients on that. Number two question was, you said what is my choice when I use it for hereditary thrombophilia?
If it is a hereditary thrombophilia, does it impact your choice of the anticoagulation when you are choosing any of the anticoagulation, whether it's a DOACs or say heparin or BK? Type of hereditary thrombophilia means antithrombin deficiency versus ferritin C as related thrombosis.
I've got your question. Can I answer? I've got your question.
Yes.
Yeah. So I think I was hearing double. I don't know. I was hearing.
Okay.
Yeah. Have you finished your question? Sorry, Ashish.
Yeah. I'm done, sir.
There was a re-echo. That's why I was wanting to clarify. Okay, I've got your question. So it depends on the type of heritable thrombophilia. Like we know, antithrombin is much more penetration regarding thrombosis than a factor V gradient, for example. Then if I have a compound, double heterozygous. So definitely, I am not aware of any guideline as such, but yes, I will give long term. And when the long term I give, it again depends. VKs are very much being used, but DOACs will be much easier to use. And we must again come to the bleeding risk. And the good thing is apixaban and rivaroxaban have shown in trials when you want to give it long-term beyond 6 months, you can give it in half the dose with the same efficacy. So a 5 milligram BD of apixaban, which I was giving, after 6 months, I give 2.5 milligram BD with the same efficacy. Their trial published data. If I give rivaroxaban, I'm giving 20 milligrams a day. I convert that to 10 milligrams a day down the line, 6 to 8 months later, but I want to give him anticoagulants. But it has been considered safe. So I'm giving half the dose for longer time with a lesser bleeding risk. So there is published data on this.
Right. Thank you, sir.
Thank you. Ashish, one more part of your question I would like to answer. If you have to choose between the DOACs, dabigatran, of course, is the baby preferred by neuro physicians. Remember one thing, that dabigatran came first, others came later on. And even the generic of dabigatran came first, then came the others. So besides publication, the experience of a neurophysician and sometimes even the vascular surgeon and cardiologist is high with dabigatran. That has been going 1 point in their favor. But recent literature shows that the little more modern DOACs or NOACs are equally good, number one. Number two, in hematology, dabigatran, remember, causes a lot of gastric problem. So when you're giving a long-term anticoagulation, you have to take this factor into account, that there is a GI problem, which other two drugs are free. And then finally coming to between apixaban and rivaroxaban. Rivaroxaban is once a day, while apixaban is twice a day. And you and me, even if we are patient, and if we have to take a drug twice a day, we have to look at the compliance. We ourselves are very often non-compliant. And these are drugs which don't require monitoring. And because they don't require monitoring, we become careless. So in practice, I have seen that between dabigatran, rivaroxaban, and apixaban, the compliance and efficacy of rivaroxaban, Xarelto, has been much superior to others because of these few issues. So that's not in the books, but that is from the practical.
Yeah, that has been the common experience, sir. So definitely, I just wanted to confirm that everybody is on the same practice.
Next question from Dr. Srimati. Are you ready now?
Dr. Ashish, I also personally use maximum my drug, which is being used is rivaroxaban actually.
Rivaroxaban, yes.
For me, maximum. Only thing is in malignancies, there's a little problem of GI, tumors. If it's there, be very careful of GI hemorrhage. So that is the only one because there's data. But in non-cancer situation, no doubt, rivaroxaban is the outright winner as far as my practice goes, and followed by apixaban.
Absolutely. Dr.
Yes, Dr. Shetty.
Dr. Srimati will come back to us. I'll ask you one question from the audience. In your experience, is there a difference in the risk of thrombosis with open end versus closed end catheter types?
I just showed you a very good slide to answer your question. The port I told you versus the PIC, and in between comes the Hickman. So let's talk of these three. Okay. So the maximum catheter-related thrombosis is in the open end in the PIC. And the minimum is in the chemo port, which is actually closed. There's nothing open to the exterior. It's minimum. So it does impact. The open ones, PIC is the maximum. And let me tell you one more interesting fact. When you put on the left side, multiple pricks, you have more instance of thrombosis. If you go right through on the right side, first shot, you have least chances in the PIC. because we do use PIC, all of us. So open has more frequency of catheter-related thrombosis compared to airport.
Right. Dr. Srimati, back to you. Are you able to connect? Okay. We'll ask one more question from the audience. Any comment on Thayer-Martin anomaly?
THEIR.
Yeah, it's in the question box. You can just open and see.
1 minute. I thought this was correct me if I'm wrong, but this was one of those venous anomalies where you get in the iliac system actually crosses each other, and you have aberrant vein or artery which causes more thrombosis on that particular side. I don't remember if this left or right, but correct me if I'm wrong, but I thought this is one of those venous aberrations or arterial aberrations which actually compresses the contralateral side and causes more. But correct me if I'm wrong, because offhand, I'll have to check this up.
Okay, if anybody of the audience knows something more about it, please tell. I don't know anything about it.
Or anybody on the panel, anybody in the panel can add.
Okay, coming back to Dr. Srimati, any chance? No. Then I think that's all the questions we have. From the faculty here, if you want to trouble Dr. Velu Nair anymore.
No, pleasure, sir, pleasure.
Okay, then I think that brings us to the end of this lovely session. What a session we had. Fantastic experience of Lieutenant General Velu Nair today. I mean, it was worth seeing those pictures, and it was scary of what you have been doing and what you have handled in your life. The medicos connected with the army will be a little jealous of you from your experience and your type of work you have done. It must be very, very daring. Very, very impressive, I must say. And thanks to all the discussants here for lovely question answer session. Thanks to our sponsor, Bayer. And for the official vote of thanks, I hand over to Bayer themselves.
Thank you very much, sir. I think it was a great session, great learning as always from you, with the pleasure of respected Lieutenant General Dr. Velu Nair, sir. So, and all the panelists and all the audience also. I think it's very important that these meetings continue to be there under the leadership of Mumbai Hematology Group and Dr. M.B. Agarwal, sir, who continues to guide all of us on the important issues in medical science. And it's really good to have his association and his support for us. So thank you one and all. And from Bayer, innovator of Rivaroxaban, we once again thank you all of you. And we would like to support you for future meetings as well, sir. Thank you.
Thank you so much. Once again, Lieutenant General Velu Nair. Salam.
Thank you, sir. Thank you, sir. I really enjoyed myself. It was a great session, and this is a topic close to my heart. And you won't believe it, one of my scientists got high altitude cerebral edema. For 1 month, he was admitted with us in Army Hospital. We had to air evacuate him on a Sunday at 15,000 feet. He got high altitude cerebral edema. And but we used to go every 4 months. It was a huge adventurous experience. We enjoyed ourselves, we bonded, and we are a family now. Thank you very much, sir, for, as usual, bringing this to the fore. And I want to thank all the panelists and the audience for the wonderful questions. And I thoroughly enjoyed it. I don't think I need lunch. I'm full. Thank you, sir. Thank you, sir. Jai Hind.
Thank you. Bye-bye. Jai Hind.
Jai Hind, sir.
Thank you so much.